Our next speaker, Dr. Deepak Kumar Gupta. Are you ready? He'll be going to talking on corneal tomography in clinical practice. Please.
Distinguished Dr. Nagpal, respected friends, dear friends, greetings from Nairobi, Kenya.
Next speaker.
I have mainly a theory presentation, and kindly excuse me, it's a very long presentation. I'll try to skip most of the basic slides and give you the practical tips. And normally we call tomography as topography. The difference between topography and tomography is basically study of the anterior surface of the cornea, while tomography is anterior surface plus posterior surface.
Sir, are these your slides? Okay, I thought there was some. Okay. Okay.
Is that all right?
Sorry. I'm sorry. I thought there was some overlap.
That was for Ashish Nagpal, the videos.
Okay. Please, go ahead.
So, the topography is study of the anterior surface. Tomography is study of the anterior, posterior and the corneal stroma. I'll be very brief. I'll be skipping the corneal optics. I'm sorry for that. I'll be skipping the optics, geometry and definitions, and these things, cardinal points, axis. I'll straight away go to the. This is because of the paucity of the time. So topography is a placido-devised technique. Tomography is can be slit scan image, or it can be shim plug, or it can be LED based. And the topography only gives angle kappa, angle alpha and lambda, which can be directly measured by the topographer. Tomographers, we do measure it and we should measure it, but it is indirect. And topography is affected by tear film and other things. And in OCT-based tomographers, stromal haze is not encountered because the wavelength being used is shorter. So these are different type of devices. And the main thing here is the elevation-based tomography. My presentation is basically on shim plug-based device, and coverage is limbus to limbus, and it evaluates both surfaces, and angle kappa is measured indirectly. So the basic map is four map refractive or composite map, and this is the picture of the map. The important thing, carry home message here is for all the general surgeons or who are doing it, we should go for the R values which are horizontal and vertical, not the flat and steep. There is a difference between R value which is flat and R value which is horizontal. And the flat value can be oblique, and we should always sit with the technician and set. This is the core of the machine. We should set these settings ourselves. Axis should always be flat meridian, and the astigmatism sign should not be plus or minus, and the zone should be 9. Asphericity should be in the Q value, and the eccentricity zone should be 6. And again I repeat, don't choose a zone as automatic. I'll inform you, I'll tell you why we keep a manual zone of 8 millimeter and black dots. So the color bar settings are two types, normalized and absolute. Normalized is when the computer adjusts. Absolutes are the absolute values. There are different increments. There are different color systems available. The absolute values are same in each system. The most common are Bell-in, Smolek. Smolek is basically used for posterior tangential elevation maps, and Ambrosio 2. It is pure theory. Anybody who's interested can learn few things. And these are the recommendations. Bell-in intuitive color map should be used for curvature maps. These are the take-home message. And Bell-in intuitive should always be used for the elevation maps. Ambrosio 2 should be used for the pachymetry maps. And these are the scales. The technicians, the company people come and they talk to the technicians. The doctor never knows. Our scale should be curvature maps 1D and 1.5D for the tangential maps. And this is important, the color scheme should be smallic. And 5 micron of the absolute scale should be for the pachymetry, and 5 micron for the elevation maps, and always 61 color. This is what you will get on the machine. And again, I want to draw your attention to these 5 points. Anybody who's doing the topography, these 5 points, there are one circle, one dot, and one line. Circle is the thinnest location, dot is the pupil center, the line is the pupillary edge. The two whites are the apex, and the diamond shaped white margin is the like minimum radius of the Kmax. I repeat, these always look for these 5 points in a topographic analysis. You don't need anything else. Just only these black points are easier to identify. These two whites are difficult. This is the Kmax reading, which is in the periphery, which shows us that there has been a misalignment. Similarly, the black dots, this area has been interpolated intelligently by the machine. And this, if you are getting this, kindly change the settings. This is the elevation map, just have the thinnest location. And tell me if I want to go slow, I'll go slow. This is the thinnest location, this look for the circle. And remember, these are the advised standard. We have to use a float, I'll explain. Optimized shift and the manual diameter. If we use auto diameter, it is less. If we use smaller diameter, it will lead to underestimation. A bigger diameter of 9 millimeter will lead to overestimation. Then these are holiday. We are not discussing holiday here. Important thing to know is technician step and the consultant step. You have a technician or the optometrist who's doing the tomography for you. The quality specification should be okay. If it is not okay, you click on the zone and you choose the minimum interpretation, the maximum extrapolation value, and you can still use it. And there should be no extrapolation in the 9 millimeter zone. This is the extrapolation. This is the extrapolation zone, and this should not be there. And if you are taking, the technician has to take 3 captures. The median K value of the Kmax should be, the average K value should be less than 3 diopters. If it is more than 3 diopters, kindly disregard it. And we have to see the misalignment and the large angle kappa. I'll just show you how to do it. And the misalignment, important thing is X is always negative in the right and the positive in the left, and Y should be either positive or negative. It is the same sign. X and X is should not be more than 200 microns or 0.2 millimeters. I'll show you the examples. I hope you can see it. Here the value of Y is in minus. Here the value of Y is in plus. This is misalignment. Large angle kappa, if you see, the X value is more than 0.42, but here it is 0.68 and 0.69. It is large angle kappa, but there is no misalignment because the value difference is not there. Because the Y and Y are similar, the X and X values are matching with each other. Consultant step is the 3 steps. He has to see what the technician has done and plus to see the astigmatic disparity. What is astigmatic disparity? Is the difference between the tomographic astigmatism and the manifest astigmatism. And tomographic astigmatism, we can have it from the 2 maps. One is the total corneal refractive map. We see at the 3 millimeter zone, this is the value 1.7. Or we subtract these, this is a manual calculation. We subtract the posterior elevation, posterior K values from the interior K values, we get the total. Here 4.7 minus 0.9 is 3.8 at 3.3 degree. 3.3 is always the flat axis. So difference of the tomographic astigmatism versus manifest astigmatism should not be more than 1 diopter. The axis should not be more than 10 degrees. If it is there, then you repeat the capture or it is invalidated. QS, I have already told you. If it is not okay, you can take the median scan. Q value should be in the 6 millimeter zone. I'm skipping these slides. K1, I repeat again, it is the flat K1. It is in the, it can be oblique but it's not the horizontal. And remember, we don't look at the colors. If we look at the horizontal of the interior curvature, if you look for the blue, it is with the rule. If it's the R vertical is blue, it is against the rule. This is the table. These are the overview. If you have a Placido based device, the K minimum should be 47 and holiday it is 48. Again, in the pentacam does not give us the true corneal refractive power. We use a subtraction method. Keratometric indices are given here. Again, take home message is if you see a posterior astigmatism more than 0.5, it is not normal. Again, the corneal apex is in the pentacam is not true corneal apex, but we take it as a 0, 0, 0. Pupil center is spirotemporal, and if the Paki you get it is less than 435, it is not normal. Again, take home message, if the y coordinate is more than 1 millimeter, it is not normal. Please note it down. And this will not come in the graphs. And again, the thinnest corneal thickness difference. This you have to do manually. You see the thinner corneal thickness between the two, right and the left. If it is there more than, if it is more than 34 microns, it is not normal. And the difference between the Paki apex and the thinnest local Paki difference. Repeat, the thinness of the cornea at the Paki apex and the thinnest local point, if it is more than 10, it is not normal. Then PS3 system I am not touching today. Keratometric power deviation has been discontinued. Again, is anterior chamber angle, we get it from the pentacam. With less than 24 is precursor for the angle closure glaucoma. When using corneal maps, we have 4 factors. You can see them. Mostly we use factor 1 and factor 2, but sometimes we use factor 3 and factor 4 also. Basically, we use refractive map, true corneal net power map, equivalent K reading, and corneal refractive power map. This is the sagittal, this is tangential. Carry home message here is tangential posterior tangential, and this is posterior tangential in diopters, this is posterior tangential in millimeters. I repeat, even the bad ectasia score will not give you, will not tell you the start of the keratoconus. This is the only map.
Sir, can I interrupt? Can you conclude, sir? I think
Yes, sir. Yes, sir. Just minutes. Can I have 1 minute?
Yeah, please. I think
yeah.
Kindly conclude.
So posterior tangential map is a precursor for the ectasias. Corneal power maps, the difference gives the spherical abrasions. Inferior superior symmetry, we take Rebowitz method, 5 points at 1.5 millimeters away. This is the average method. We take in the second circle, decrease it. These are the values for the atypical values. Reference, just remember the computer calculates the average reference surface and gives us the value. This has been devised by Ambrosio. I'm not going into the details. These are the values. Just remember, even the 2 standard deviation values are 2 standard deviation is equal to 94.5% of the values. This is the principle. We should also see these things are not seen. Front elevation thickness and back elevation thickness. This should not be more than 10 microns. Progression index is also important in PS3 system. This is in green, blue. The average values I'll just show you. Average values are 0.8 to 1.1. If it is less than 0.8, it is corneal edema, or more, it is abnormal cornea. Relative pachymetry is just like elevation maps. It was devised by Holiday. Asphericity, we all know. Thank you very much. It was a huge presentation. I don't know whether I have done justice to it, but I tried my best. Thank you, sir.
Thank you. Thank you, Dr. Deepak, for a very exhaustive review. I think I request the next speaker to be ready. Okay. And I think my takeaway would be that I think it's very important to know your machine. And I think those are the highlights that you were pointing out, that you should know all the parameters. Otherwise, we end up reading just the colorful maps